Okay, well, yeah, thank you. So we have just under half of the people back from break. I see everyone's very excited and interested in networking and talking, and that's exactly what these meetings are for. And I acknowledge that we don't give enough time for that, and so we'll take that into account for our next meeting. But they will be streaming in here soon because we have a few people wrangling people up now. So I'm going to introduce the next panel. Okay, great. So communicating health equity is our next session. And I want to welcome back the folks online. I've also been a little neglectful of the folks online every time we come back from a break or leave for a break. So thank you very much for those of you who are hanging in there with us, and welcome to those of you who are just joining us for our last couple of sessions here. I think it's great that you've been hanging in there with us. So I'd like to introduce Sarah Klein. Sarah, as I've referred to a couple times already today, is the mastermind behind producing these videos. You've seen one on Push Buffalo. You will be seeing the two additional ones, I think one after this session, and then you'll see one starring Puni Jackson, who you've already heard from today toward the end of the meeting. So let me just introduce Sarah. Sarah co-founded Red Glass Pictures with Tom Mason in 2008 as a platform for directing short films and video installations. She also co-directed a 16-part video installation series for the USA Pavilion at Expo Milan featuring the President and Michelle Obama. I'd also like to introduce Nicole Bronzan. Come on down. Yay. Nicole's well known in the audience here. So Nicole is a senior communications officer at the Robert Wood Johnson Foundation. She's been with the foundation since 2015. She brings her journalistic roots and advocate's passion to the foundation's work to ensure that everyone has the opportunity for a healthier life. And she spent her formative years as an editor at the New York Times. All right, our very own Laura DeStefano, I mentioned earlier before, introduced her before, but what I didn't mention is that she, before coming to the Academy, she was the manager of the AEI Press, the in-house book publisher for the American Enterprise Institute. And last but definitely not least is Dwayne Proctor, who is the senior advisor. Yay! Another well-known one to our group. Senior advisor to the president and director of the Achieving Health Equity Program Management Team at the Robert Wood Johnson Foundation. Dr. Proctor came to RWJF in 2002 as a senior communications and program officer, providing strategic guidance and resources for several child health and risk prevention initiatives. But before coming to the foundation, he was an assistant professor at the University of Connecticut School of Medicine, where he taught courses on health communication and marketing to multicultural populations. And he also was a Fulbright in Senegal, West Africa. And his research team investigated how HIV/AIDS prevention messages raised awareness of AIDS as a national health problem. And I'm not going to forget this one. I told him I didn't see this on his bio. I think I just forgot to read the last sentence, unfortunately. Here it is. He is the former chairman of the board of directors for the Association of Black Foundation Executives and currently is the chairman of the board of trustees for the NAACP Foundation. So we welcome this illustrious panel.
Okay, so it's the afternoon. Let's loosen this up a little bit. I'm Sarah Klein. I feel like I wanted to think about what I could do in 5 minutes to kind of give any tips or expertise I have to you, because you have such amazing, you represent such amazing institutions, such amazing groups, And I feel sort of like a tourist in a world of people doing amazing, amazing work. So, so I wanted to take a minute as a filmmaker and as someone who has been for almost 2 decades telling the stories of organizations, you know, corporations, museums, a lot of different things. I wanted to kind of take a minute to just talk a little bit quickly about creating messaging or videos for the organizations that you represent, and then we'll go to the actual experts in this area. But just from a perspective as a filmmaker, an outsider, I just want to say that the first thing I would say, and this is what I would say to anyone who came to me saying we want a video about our organization, we want to tell our story, we want to communicate who we are effectively to the general public. I would definitely say, first and foremost, whatever you do needs to be personal, narrative-led, story-based. Not a lot of facts and figures, not a lot of big clinical ideas, but story, story, story. I'm sure everybody knows that, but I would say in a short video, it's crucial. I would say number 2, do not treat your video like it's a paper or you know, an article in a newspaper. Think of it as an emotional, 3 points max. Nobody's going to remember more than 3 important things that you communicate, so you got to pick those really wisely. This goes for a $500 video. It goes for a $5 million video. I don't care. It's really, really, really about these basic things. The piece should always end with a "this is why I'm telling you this" moment. So you can say 1,000 things to people. And actually, Ira Glass is the one who said this. This is just me regurgitating it. But at the last piece should always include, "and this is why I'm telling you this." So, you know, my organization is meeting this need. This is the problem we're facing. This is our story. And I'm telling you this because, not just to tell you, but because I want to communicate something. I want an action item. I want something to be taken from this. And I know what it is. And let's see, do I have a final thing? I would say that, you know, these videos, if you're looking at social media, 5 minutes max. I think a lot of us know that, but oftentimes organizations come to us and want like a 10 to 30-minute video talking about who they are. And I really, really ask people to want to think to themselves, like, who is going to watch this video and where is it going to live? Because if we know anything, we're in a world where it's got to be quick. And so anyway, that's my quick summation for you. Super excited to be here and to hear really the deep, deep diving work that these 3 people are doing. So let me turn it over to you, Nicole, and and tell us just a little bit about what you're doing.
Sure. Is this okay? Sound-wise? Okay. Great, and my slides are up. So really, I'm a communicator, right? That's what I do. And I think part of the challenge and part of the opportunity, too, of being a communicator is that you're trying to dive deep into something that we all do every day, right? We walk through life, we communicate with each other. So when we're trying to talk about a concept like equity, again, she stole my main points here, but you know, stories are really key, and I think when we're talking about anything, that's true, but especially when we're talking about a concept like equity, where in some cases people have some preconceived notions, they may not understand the term fully. I'll talk a little bit more about why in America in particular, this is just a term that is a little bit loaded. So in short, I don't need to tell you what equity means because we're all here for that, right? But we want to make the point in our communications that, first of all, health is not just about being sick. It's not just even about medical care and genetics, right? Health is about everything we do, and everything in our lives affects our health. So that's the first point. And I think, you know, as a community, as a country, we're getting there. So that's kind of the first place that we start. And I'm already doing this wrong. Did I just push the green thing? Okay. There we go. So just to dig into the research just a little bit, one of the things that we thought, excuse me, was really, really important was to have a definition for what equity actually is. So not just so that we have the sense ourselves, but so that we can measure our progress. Pay close attention here. I won't read it to you, but fair and just opportunity. So in America in particular, we talk about the land of opportunity, right? And that here, anyone can make it. You can have the American dream, right? We want a fair and just opportunity, though, which is actually not what we have here. So that's the clear point here that we want to make. We want to remove the obstacles because some people have obstacles that others don't. And we want to make sure that we can look back at this and say, did we actually do these things? Did we improve the opportunity for everyone? So that's just a quick dive into our official definition. So now talking about health equity. It's not easy, right? It's not a term that rolls off the tongue. I think in America in particular, we talk a lot about equality, and it's in all of our sort of pledges and all of our propaganda about what a great country we are. So we want to be very clear, we're not talking about equality, we're talking about equity, and that means everybody gets what they need, which is not always the same thing. So we developed this graphic actually to make that point. And that is actually online and social and everything else, so you can see it. And what we're learning really is that there are a lot of different ways to talk about health equity. It doesn't really matter that you say the words health equity, but that you connect with the audience about this main point, about opportunity. There are various terms here that you see that we've found to resonate with other folks, with specific audiences. But really it's about sharing real stories, connecting with people, and getting them engaged instead of pushing them away. And then lastly, we want to make sure we're not just talking about disparities here, because that's where the conversation has come from. All the research sort of started there. How did we get here? Why are we, in this place where there are these big gaps? So we want to move from disparities to equity by taking the conversation from problems to solutions, from deficits to opportunities, and from despair to hope. And that's where the storytelling really comes in.
If we could pull up my slides, please. So I want to take the conversation back to the goals of the Culture of Health program. Thank you. Here at the NIM, Kimber touched on these briefly, and they are in your agenda. But the first goal is to lead, and that's to build the scientific evidence base. The second goal is to translate that science to action so that we don't just have books sitting on a shelf. The third goal is to create impact by building capacity within communities. And the fourth goal, its a big one, is actually to transform culture in order to sustain the impact that we have. So when we talk about communications and the role of communications here and talking about health equity, we're really focusing on translating the science and sustaining that conversation. So I have here a quote from the Communities in Action report. In vastly oversimplified terms, the report stated that communities have tremendous power to be leaders. They're capable of affecting great change, but they do need partners, they do need supportive policies, they do need funding. So how do we translate that bit of science? So one of the things we've done is created a health equity hub, and you can find it online at nationalacademies.org/health equity hub. This is just one screenshot from it, but I think it's the most robust area. We've actually created sector briefs for all of the different sectors that you see listed on the screen here. So these are 4-page overviews of the key principles and action steps from the report. Those are available in print and HTML format, and so we're working to distribute those as broadly as possible. You already know about the video series that I described earlier, but we're trying to uplift the stories of some of the communities that are doing great work in this area. There is no cookie-cutter approach, as many of you have mentioned. There's no one-size-fits-all solution. So what we want to do is tell the unique stories of communities and hope that others are able to pull out principles that could apply to their own work, and of course, just to be inspired that change really is possible. Moving now to the question of sustaining this conversation, I have another quote from the report. Really what this says is that culture change is needed. There's a lot of work still to be done in talking about health equity and educating people about the role of social determinants of health. And so at the academies, we're trying to keep that conversation going as much as we can, and we have a number of tactics to do that. One of the first is a Community Health Heroes interview series, which is an online interview series we publish monthly, talking to people who are doing innovative work in this area. You can find that on our website. As Velma mentioned earlier, we are also soon to publish a collection of essays on the intersection of health equity and social determinants of health. This has a wide range of different focus areas. It covers fetal alcohol syndrome, Native Hawaiian health, violence in Black neighborhoods, the way Black men are portrayed in the media, a whole range of things. We're hoping that'll be available in the next month. And then finally, you've heard about this before, but we have the Visualize Health Equity Art Show. Many of you have seen the gallery just outside. I do want to mention that we will be having a reception at the close of this meeting. We're expecting about 20 artists who are represented in the show to be here in person, so I do hope that you will stay and talk to them. We also have an online permanent digital gallery, which you can see here on the screen, with over 100 pieces of art. Each piece is accompanied by an artist's statement describing what health equity means to them and how their artwork relates to it. There's also a comment field so that you can add anything that the art evokes for you. This is just an example of a detail page on that digital gallery. So that's available now at nam.edu/visualizehealthequity. Please check it out and share it. And then finally, just to mention, we're trying to keep the conversation going on social media. We're using the hashtag #PromoteHealthEquity. So I have a couple snippets here. You can see how people are using this out in the real world. And I hope that you will join us. Thank you.
Hello. Hello. All right, right on. Hey, everybody, how are you? I'm Dwayne, and I'm very glad to be here today to talk to you about this project. This is a kind of a passion project for me in a lot of different ways. I don't expect everyone to believe everything that I believe, but I know what I do believe, and I don't believe in race. Not at all. Don't believe in the Easter Bunny, don't believe in Santa Claus, don't believe in race. Not at all. I believe in racism. Oh, yeah, for sure. I believe in discrimination. Definitely, definitely. And so doing this project, when you work in health equity, coming from a position of social justice, you're also coming from a position of love. And if you don't believe in race, or like I don't believe in race, that also means that you love all people as all of your relations, right? Okay, so my family, being from Washington, D.C., and being from West Virginia, every complexion that's in this room is in my family, right? And so when we started talking about this project in particular, the whole idea was we knew that there was a lot of pain out there because people felt like they were facing lots of discrimination. And so if you love people and you know they're in pain, and so then you go right to the pain point and you try to pull it up. So this is what we did in this project. We got together with the Harvard, with their School of Public Health, the T.H. Chan School of Public Health, and NPR, and did one of the largest polls that we've ever tried to accomplish, making certain that we had representative samples from at least 5 major ethnic group collectives in the country. Okay, so African Americans, Latinos, Native Americans, Pacific Islanders and Asian Americans, and European Americans who identified themselves as white, right? And we also made certain that we could have a representative sample of people from the LGBTQ community. And doing this poll means we have enough data to cut the data for men and women as well. Now, what we wanted to look at was perceived discrimination. Do people feel like they've been discriminated against? And we looked at that across 13 different sectors of their life. Do they feel like they've been discriminated against in school, in education, in interactions with the police, the healthcare system, et cetera? Harvard's role is to put out the, Harvard's role was to do the report and do the analysis, and the analysis is done. They are going to release each bit of the report every other week on each group that I mentioned before, and this will end around the middle of December. NPR's work, and the best thing about working with NPR is that they have access to the Morning Edition, Code Talk, Code Switch, all of the story channels that they have. And NPR's role is to come up with real stories of real people to talk about the discrimination that they faced every couple of weeks when they release these reports. The reason why this was so important for the Robert Wood Johnson Foundation is that our goal is to build a culture of health with all of you and everyone else across the country. If we can have a culture of health in our nation where it's inclusive and people feel respected and they're part of the process, meaning they have the ability to say what they need in their lives, that's what power is all about, and to be able to express those things and get those things. So we know that you have to have that to have a culture of health. You have to eliminate health disparities to have a culture of health, and you have to achieve health equity to have a culture of health. So that's why we got involved in this. I want to share with you just an overview of some of the findings that have been released. I'm not going to share with you the findings that have not been released. They would shoot me, I'm sure. Although they're nice people, I'm sure they have guns. So we'll see how it goes. We'll see how it goes. So here's where we begin. Let's take a look at this. Who experiences discrimination? We put this out when we put out the first release on African Americans. This past week it was Latinos. Next week we'll do European Americans who identified as white. These are the percent of each group saying that they feel like they're discriminated against. African Americans, seemingly the highest, right, closely followed by the LGBTQ community. right? Latinos and Native Americans, 78, 75% there. Asian Americans, 61%, and 55% of those whites felt that they have been discriminated against as well. When you ask why folks feel discriminated against, or in what context they feel discriminated against, for whites it came up as unequal pay, unequal treatment in the education system, unequal ability to get jobs, et cetera, like that. For African Americans, it was a host of a variety of different things. And then for Latinos and Latinas in particular, stated that they have been discriminated against in the healthcare system. African Americans said they have been discriminated against in the healthcare system, in the public safety system, and others. So the reports are coming out one by one. This is important to us, though. Not only does perceptions of discrimination increase your stress, okay, and your ability and to just walk out your door and not feel like your back is up against the wall every time you interact with other people. Discrimination also is against the law, right? But if it's keeping people from engaging with our systems because they perceive that they will be discriminated against in our systems, this is a bigger problem. So let's take a look. There's this avoidance of discrimination. The percent of each group here saying that they have avoided going to a doctor or seeking health care due to concerns of being discriminated against or treated poorly. African Americans, 22%, Latinos, 17%, whites, 3% on there. But this avoidance is really, really important. So in healthcare, sometimes we hear from our physicians that certain groups of people seem to be non-compliant. Okay, or people don't show up for their appointments, or they don't fill the prescriptions after they get them, okay? Well, if you think you're being discriminated against and you don't even show up, then you have that opportunity for your chronic health conditions to just get worse and worse and worse. And that may be part of the reason for some of the health disparities that we see. Discrimination in the workplace. Percent of each group saying that they have ever been personally discriminated against when applying for jobs or being paid and promoted. So the yellow bar represents being paid or promoted. The blue bar it represents those who felt discriminated against while applying for jobs. As you can see here, African Americans nearly at the 60% mark, Latinos about a third in each category, and Europeans, Americans, and those who identify as white between 13 and 19% there. This is very important too, and this may get you to some of the sensibilities in the country about why things are so different. You hear about a divide, a divisiveness that's going on, but if people feel like they're being discriminated against and their life experiences are telling them that they're discriminated against, then for certain, this is an issue that we need to take up. Because if every single group that we looked at feel discriminated against, who is doing the discriminating, right? It's a really interesting question to get to the bottom of. And that's the end of my presentation. Thank you.
All right. I think I want to start with you, Dwayne, because we just heard you. And of course, I have 1,000 questions, but I'm going to ask you one.
Sure, go ahead.
So first of all, were you surprised by your findings? And based on these findings, what is a actionable way forward?
Yeah, I'll tell you for straight up. When I saw that whites felt like they were discriminated against, nearly 50% of the sample that was there, that was fascinating to me. That was a finding that I did not expect to see. Otherwise, for the other groups, I've seen some of the discrimination that my LGBTQ friends have gone through. And we're talking about social discrimination, right? Because if it's real discrimination, you can take it to court and there's laws against it. I think what actionable is that our country needs to have not only a timeout, but we need to have a sit-down conversation about who we want to be as a nation, who we are as a people, and where do we want to go from here. And if it means that we have to lay on the table what the sins of the past have been in order to get to the future, then we just need to lay it on the table and get there, because we can't just keep avoiding the issue. We can't not keep talking about it. We're really talking about people's lives here. So I've always thought that at least in public health, it would be nice if we had something similar to a Truth and Reconciliation Commission where we could actually admit the faults and the sins, at least to public health, because that's all I can control, right? To start that conversation to say, okay, this is what has happened, and this is how we responded, and we may not have done it equitably, we may not have done it fairly, we may not have done it justly, and we need to put that out there and then think about what the solutions are moving forward.
Reminds me of what happened in Rwanda after the genocide, and on a neighborhood level that happened. Some really intense conversation. I wonder, I don't know.
And you know, and I think if we have that conversation, sure, there's going to be some shame, there's going to be some blame, but it'll be on all sides too. You know, speaking from my background, my personal background. My mom's family is ultimately from Senegal in West Africa. My father's family is ultimately from northern Ghana, part of the Fanti tribe. Not being able to protect your women, not being able not to be captured, not being able to fight back, not being able to have control over your destiny for 400 years, there's shame there too, and there's guilt there too. And so I think if we open up our conversations and we do these in these ways, that we will hear pain and hurt from either being abused or being an abuser, or not being able to be to control your destiny in the way that you would have wanted to do.
Super interesting. So Nicole, the term health equity sounds about as like fascinating as as cardboard, actually, just from an outsider's perspective.
Thanks a lot.
So, you know, there are clearly challenges to making that term actually resonate, and you talked a little bit about it. But so, how do you turn this sort of seemingly clinical term into something relatable to, you know, we're talking teenagers, college students, then of course policymakers and you know, anyone in between. But how does that phrase how do you bring that to life?
So I just want to say, starting off, I totally agree. And also in our defense, I think, you know, one of the things that we're stressing more than ever, I think, is really that health equity as a term has a definition for measurement, and it has a definition for actionable solutions. Out in the world, it doesn't mean much. So we really encourage people to talk about what matters, right? What matters is opportunity and fairness and health, and that everyone can live, you know, a full and happy life. So we try to sort of, it's almost like the sort of like in the family conversation, and then when you go out, you don't talk about health equity, you talk about opportunity. So that's kind of how we do it with the training too. So we want to hear stories, we want to hear, you know, we want to hear about the family who literally is picking the pears but can't afford groceries. Right? We want to hear about the, you know, the construction worker whose commute takes 3 hours to go 4 miles because his bus line, you know, he has to catch 3 buses and, you know, 2 trains or whatever. So those are really what we want to talk about. And at the end of the day, you know, equity is the principle, but it's not necessarily the words that need to come out of your mouth. And I think that's really what we want to get out there more than anything.
No, that makes a lot of sense. So I guess I'll move on to Laura and then I'll open it up because I think people have a lot of questions. Laura, so you at the National Academy of Medicine started this project, and I'm sure you know, looked into all these different communities and had all these ideas of what you may or may not find, and then you guys actually headed out into these communities. What surprised you? What intrigued you? What was it like to actually be on the ground in these communities, seeing the actual problems that were happening?
Yeah, first I'd like to echo what Charlie said earlier and thank these communities. Thank you all very, very much for taking the time to let us visit. I thought I was busy, you guys are busy, so thank you. For me, it was a very special experience. You know, I sit at a desk, I work in DC, I think at the national level, I think in very abstract terms. I never get a chance to go into the community. And it was so inspiring. You know, I tend to get a little bit in a rut, I get a little cynical, I think nothing's gonna change. And when I went to the communities, I saw that a lot is changing. Lives are changing, you know, whole neighborhoods are changing. So I would highly encourage anyone like me who's in kind of an administrative desk role to try to get out there, because it really makes the work that I do tangible and really worthwhile.
Follow up, because I think everybody in this room is excited to have the National Academy of Medicine involved in their communities. So what are things, you've talked about some things you can do. What are further things you see the National Academy of Medicine able to do to kind of elevate the conversation, bring these communities together, push this forward?
Sure. So we've got another 2 to 3 years in the program. We might extend it further. The next phase of work, as Charlie described a bit, is to do what we're calling kind of an incubation project in communities, to go out and help communities develop implementation plans. We're obviously going to be collecting a lot of data and a lot of insights throughout that process. And what we want to do is make those easily accessible and user-friendly for communities around the country. So we're going to be thinking about creating some kind of knowledge repository with easy-to-digest resources, with experts available to help. That's something that we're going to be discussing in more detail tomorrow, but that's something we're hopeful we can effect. We also are going to be developing some educational materials. I've already heard that a college curriculum has been developed around the Communities in Action report. So if that's something that we can kind of package and make available, that could be very powerful. And we want to think younger than college, too. We want to think about making discussion guides for high school students, maybe getting even younger children involved in something like an art show, like another iteration of the art show. So there's a lot of possibilities out there, so stay tuned.
Great. So do we have time to open this up for questions or no? Okay, sorry. Never mind.